Looks good on this end.
Great.
I think we're getting to a good quorum. And Guy, I see you're on, so we're in good shape. And we can give it maybe one more minute before we get started. I think we'll be expecting a few more folks. Well, I know we have a pretty full agenda, so I think, Olivia, I think we can get started. And I think at first I'll just say, welcome everyone. I'm going to pass it quickly to Guy, who's going to just say hello on behalf of CTDSS, and I'll say hello as well after that. So Guy, let me pass it over to you.
Great. Thanks so much, Brad. Nice to see you all, at least virtually. For those of you who don't know me, I'm Guy Woolston. I'm the Medicaid director. I just wanted to start with a very quick thank you. Thank you for accepting this invitation to participate in DSS's Primary Care Advisory Committee. We're at the very beginning of a journey thinking about if and how we should redesign our primary care program. And I know you were all really busy. Your input is really important. I just wanted to start with like a heartfelt thank you for taking the time out of your valuable days. Just to put a little context, I think this work really begins with a recognition that high quality primary care is the foundation of our healthcare system, and having high quality primary care is critical to a lot of the goals that I share. I know the commissioner and the governor shares, and I think many of you do as well. And as we're thinking about primary care, we're going to be guided by the goal of having, as Brad likes to say, biopsychosocial health and the well-being of our members in a way that helps keep members healthy with a particular focus on disparities. And I just want to say thanks again. And I want to encourage you all to be active participants. We're setting this up because we want to hear from you about the challenges and the problems of the status quo, as well as some potential solutions. So I really appreciate the candid discussion, and thank you again.
Great, thanks, Guy. And I'll just introduce myself briefly. I'm Brad Richards. I know many of you on here, and also just a heartfelt thank you for joining and participating. I'm the Chief Medical Officer, Medical Director, work with Guy very closely. And I'm a general internist by training and consider myself a primary care provider, and had my own panel for a number of years. And I know just from my own experience, taking care of mostly Medicaid members, that there's a huge opportunity for us to do a better job. I think that there's a lot of members who get great care, but there's a lot of folks who could get better care, especially for their individualized needs. And I think coming here with the spirit of hoping to work with all of you and thinking about how we can achieve that. And I'm very pleased that we have, and some of you know them already, the Faulkner Consulting Group helping us with this work. Many of you may have seen them previously at MAPOC meetings or care management meetings or other venues. They've also helped us with our maternity bundle work. And so they will be helping and assisting with this process, and very grateful for their expertise and support through this. And I'll quickly turn it over to Olivia to probably say hi on the Faulkner side and kind of get our meeting going.
Awesome. Thanks, Brad. Hi, everyone. By way of brief introduction, I'm Olivia Burke with Faulkner Consulting Group. I am joined by Deb and Tiffany, who are also supporting this project, and from the FCG side, and who will probably jump in at different points as we go. I'm going to go ahead and get us started, given that we have a fairly full agenda. So that you have a sense of where we're headed in this meeting, we wanted to start with just some broad context for this work at the level of national, state, and department level priorities, and then talk a little bit about the work that's been done to date, which has been a primary care program assessment, an assessment of sort of opportunities and some recommendations around DSS's sort of starting point, right, in terms of the existing primary care programs. So we wanted to have you all to have those sort of two pieces of sort of background and context for this work as we dive in here. And then we'll take some time to talk about the stakeholder and process, how that's envisioned to work, the roles of this committee and the upcoming sort of meeting structure for this committee. And then we really want to spend substantial time in this meeting turning it over to you all as well to introduce yourselves to us, to each other, to talk a little bit about, you know, where you come from in terms of your perspective, who you represent, and what your priorities for this work are. I know many of you responded to pre-meeting questions and in advance of this meeting. We appreciate that and wanted to give, you know, each of you a few minutes to sort of speak to some of the thoughts that you put time into developing. So a note on questions and comments, we will have some time at the end for sort of general discussion. Of course, if you have, you know, direct questions as we go, please raise a hand or chat them. We can certainly stop, and I will, you know, sort of pause between sections to see if, you know, if folks have any questions or comments sort of along the way. But with that, I will start and just sort of start at the highest level and echo briefly, you know, what Guy said, which is that this work really starts from a recognition that high quality primary care is the bedrock of a high functioning healthcare system. There are a number of different indicators that primary care is a system in trouble, indicators of expenditures on primary care, of primary care utilization, of a shrinking workforce in terms of primary care physicians. And so this work departs from that recognition, but also takes, you know, as its starting point that primary care is really foundational to improving member health outcomes and to advancing equity. I want to also acknowledge just very quickly that as we think about primary care redesign, we are also looking to federal priorities in terms of CMS partnership. And that this work is very much aligned with those federal priorities. On the left-hand side, you'll see articulated some of the strategic objectives of the CMS Innovation Center, which are around driving accountable care and around quality, both across Medicare and Medicaid populations. And then on the right-hand side, you'll see an articulation of the federal priority around improving health equity through measurement and incentives. And so at the federal level, we are very much, you know, aligning with those broad priorities. I'm going to talk quickly as well about some state level context here and say, you know, this work is not happening in a vacuum. It is part of a sort of coordinated multi-payer strategy that many of you are participating, I'm sure, in different ways, really around supporting the state's primary care infrastructure. And so this work is being done, you know, in alignment with the work that is being done across the state, taking, for example, the work that the Office of the State Comptroller is doing around the State Employee Health Plan, as well as, you know, the Office of Health Strategy and their work in leading the roadmap for strengthening and sustaining primary care. And so as we set out, you know, to think about, you know, what DSS wants to do in the primary care space, it's worth acknowledging that there are, you know, two objectives. One, to recognize the unique needs of the Husky Health population and to incorporate a strong focus on addressing health-related social needs, SDOH needs, and promoting equity, while simultaneously working in alignment with other payers, looking for opportunities for multi-payer alignment, recognizing that that's important to reducing provider administrative burden and also to maximizing the impact of any program that DSS develops in the primary care space. In terms of DSS's goals, so thinking at the department level, wanted to acknowledge that there are a set of goals and strategies that DSS has previously established for the development of the primary care programs and primary care goals. These have guided some of the work that's been done to date in terms of the primary care program assessment, and certainly will guide work as we go forward into the program design process. And so you'll see there are on the left-hand side two major end goals. The first being to improve the biopsychosocial health and well-being of Husky Health members, especially for the most historically disadvantaged, in a way that reduces inequities and racial disparities. And second, a goal or a need to be fiscally responsible and sustainable, and to ensure that any increases in primary care spending are offset by improvements in member outcomes, and never by restricting access to services. On the right-hand side, you'll see a set of strategies. These will guide sort of how we look to achieve those goals. And they are 5. First, to incorporate health equity as a guiding principle for system change. Second, to maintain member choice and access. Third, to uphold a model of mutual accountability. So here thinking about equipping providers with the tools and the funding and the flexibility to do the sorts of things that allow them to fully address member needs and take accountability for outcomes and improvements in outcomes. 4, you'll see maximizing program impact. And here we're thinking again towards that participation in broader statewide efforts, the pursuit of multi-payer alignment, making sure that the program is appealing to providers and that it's aligned with other reform initiatives around specialty care, behavioral health care, and community-based services. So again, that this work is not happening in a vacuum, but is well aligned with other efforts underway. And then finally, the sort of 5th strategy you'll see listed is any program design should be data, evidence, and member experience informed. We want to build on the successes and learn from the failures of similar efforts, and really adopt a test and learn mindset as we move forward in this process. That can sound somewhat abstract. And so we wanted to also take a minute to think about goals in a slightly more sort of tangible and empirical way, which is to say, as we think about what a successful primary care program design would do, how do we think about that, and how can we start to think about measures that would help us to understand if the program is achieving those goals. So here you'll say what I'll caveat is at this point essentially a draft framework, right? There are some measure examples, certainly welcome thoughts on those measures, and are happy to refine. I think this will be a point of discussion as we go, in a place where your input will be fantastic, and really critical to making sure we all agree on what exactly success looks like for such a program. But we've started by outlining a framework here, with really 4 domains that said a successful primary care program should, 1, improve quality of care. Here, thinking about broad-based measures of screening and prevention. You'll see a few examples listed: breast cancer screening, diabetes care, well care visits. 2, it should improve patient and provider experience, measured by some of the existing survey instruments, CAP survey for members, as well as the provider satisfaction survey that's in place. 3, it should reduce disparities in care. And so here we're thinking about measures across the other 3 domains, segmented by race, ethnicity. And 4, a successful primary care program would result in more health core resources being expended on preventive care instead of acute care. And so here, thinking about measures of primary care versus acute care spending and utilization, things like primary care expenditures as a share of total medical expenditures, as well as acute care utilization, thinking of ED visits and inpatient admissions and those kinds of things. Again, just a starting point, and one that we will welcome your thoughts on as we get to a set of measures around which we have broad agreement for measuring program success. The next section here is another piece of context around some of the work that's been done to date. I'm going to go ahead and move into that, and then I'll pause. But just to say, for your awareness as we move into this work, we are building off of some work that was conducted last year, the Primary Care Program Assessment Project, which really looked at where are the opportunities around the existing primary care programs, the PCMH program and the PCMH Plus program. That work started with a sort of more quantitative assessment, looking at data, reports, other program documentation, and then moved into a primary data collection phase, which was really oriented towards conducting focus groups, conducted 11 focus groups, 4 with members, 4 with providers, and 3 with other key non-member, non-provider stakeholders to understand stakeholder priorities and where the opportunities for improvement were. All of that culminated in the development of a set of recommendations for primary care program design. And so we wanted to highlight for you all just, contextually some of the key learnings that will inform this process and recommendations. I will note that we also sent out an appendix that had a lot more detail around the findings from both of the phase 1 and phase 2 assessments. So, certainly welcome your thoughts and questions, and happy to provide more context there if you're interested. But I think as we move forward, 2 things that will guide this work and that are sort of the highest level findings in terms of opportunities for improvement. From a quantitative perspective, as we look at the data around quality of care and member outcomes, we see that there are disparities by race and ethnicity. What you're looking at here is a selection of measures. On the left-hand side, ED utilization, so a measure of acute care utilization. Here, lower is better, unlike for the other measures where higher is better. So just a note there. And what you'll see is that, for Black and Hispanic Husky Health members, the rates of ED utilization are higher than for other race ethnicity segments. And so, while of course not all ED visits are preventable, we do know that preventative care can help to reduce the use of acute care, can help to reduce ED utilization if successful, and taken in combination with some of the measures across other domains, which you'll see here on the right-hand side, measures of access and availability to care, measures of prevention and screening, measures of behavioral health management. What we see is that there are disparities in terms of member outcomes by race and ethnicity. And so as we think about why that is and what can be done to improve that and to advance the department's goal to improve member outcomes and to advance an equity agenda, I want to turn to some of the learnings from the focus group discussions from the more qualitative component of the assessment. Again, this was a set of focus groups with members, with providers, and with other non-member provider stakeholders. And when asked, what the major barriers to the equitable delivery of care and member health outcomes were, we got a long list of barriers around which there was a lot of agreement. Things like access to transportation, housing and food security, translation supports, technology-enabled care, behavioral health access, extended care hours, disability access, cultural competency, workforce diversity, to name those around which we, heard the most. And when asked, where are the biggest opportunities to improve the primary care system and advance health and equity, we heard really 3 big things. First, to identify and address health-related social needs more effectively. Providers talked quite a bit about the difficulty of that work and the lack of resources for it, the importance in terms of things like, if I have a patient who needs insulin and they don't have a refrigerator, that's a huge problem, but it's hard for me to solve that within the confines of the current reimbursement structure. Two, we heard that it's really important to enhance care coordination, especially through expanded care teams that include community and peer-based health workers. We heard a lot about the importance of integrating community and peer-based health workers as supports for Husky Health members in navigating the system. And that, you know, there's really a disproportionate need for that kind of support amongst Husky Health members. And then three, we heard a lot about ensuring that members have easy and timely access to care, you know, including through technology-enabled care options. So we heard excitement from members around telehealth and the expansion of that, you know, especially during the pandemic in terms of creating easier access to care in many instances. We also heard from providers about the potential for those options, you know, inclusive of telehealth and a broader array of sort of technology-enabled care options to improve easy and timely access to care. And so together, this sort of set of opportunities gave us a starting point for thinking about what any future primary care program should do. And so the work of last year culminated in a set of recommendations, you know, which are a fairly high level and which will be, you know, sort of further defined through the program design process that we are embarking on now with you all. But just to say, in response to the findings, you know, that we've highlighted and that are more numerous in the details there, we developed a set of recommendations really across three domains. The first being care delivery redesign. And here we said, well, there's a real opportunity to provide support for practices to deliver high quality primary care with a focus on expanded care teams, on enhanced care coordination and technology enabled care modalities that can support easy and timely access to care, behavioral health integration, identifying and addressing health-related social needs, and promoting equity. From a performance measurement perspective, the recommendation was to establish a performance measurement program that drives accountability and improvement with an enhanced focus on measuring and addressing disparities in care, and ensuring that data is available to support provider performance improvement and ongoing program monitoring. And then from a payment perspective, ensuring that any payment model supports those goals and advances biopsychosocial health and drives accountability for outcomes. I'll note also that there are sort of two cross-cutting recommendations. The top, you'll see the development of a cross-cutting equity strategy with the goal of reducing inequities and racial disparities. That's something that we imagine really cuts across care delivery redesign, performance measurement, and payment, would really be integrated across sort of all dimensions of a program. And then the other sort of cross-cutting dimension, just again to nod to the importance of multi-payer alignment on select design features to the extent that that is possible within the program development. And so as we sort of set out on this process of program design, I think, you know, you'll see there's a sort of set of core program components articulated here on the right-hand side, sort of, you know, building blocks, if you will, for any program, things like care coordination, quality measurement program, payment model. And so the work of this group, you know, will really be, we're envisioning taking up each one of those sort of key program components and looking for, you know, your support in defining that element in terms of how it is structured from a program design perspective. So as we move forward, we're going to be sort of making more tangible each one of those recommendations in terms of a program design, and wanted you to also have, you know, as we start to do that, a sense of the envisioned program scope, which is to say, DSS is aiming to develop a broad-based program that maximizes program impact and ensures that program benefits are widely distributed. That means tailoring program designs to ensure that FQHCs and small providers can participate, utilizing different tracks with distinct requirements as needed to ensure that that is possible. And then from a membership perspective, it means including all Husky members who are attributed to a PCP. Because of the unique cost structure associated with dual eligibles, the proposed approach is to exclude duals, at least initially. And then while there's a recognition that tailoring the program design for other special populations would enable us to integrate sort of more targeted and in some cases appropriate measures and incentives, that is going to be phased in really to allow DSS to first focus on the development of a core program model that then can be customized for different populations, thinking, for example, of pediatrics and pediatric focused quality measures. So wanted you all to have that sort of broad context as we start down this path. I will say just a few more things in terms of sort of thinking about how we envision moving through this work with you all going forward. We are targeting a new program launch as of July of 2024. So you'll see that this timeline is set up in order to reach that goal. That means that program design is complete by the end of the summer, that technical design follows on that pretty quickly. And then there are some state budget and federal authority milestones as well around a state budget request and the submission of a state plan amendment in order to enable that program. So that is the sort of broad timeline under which this work is going to be organized. That means from the perspective of this committee, we'll be looking to take up each month, as I said, one of the sort of core program components of the program design. So, we'd be looking next month to begin to talk about care delivery redesign priorities, moving from there into some payment model discussion, and then into quality measurement and data sharing discussion. So this is the at least currently envisioned sort of trajectory for this committee, although of course things may shift as we go down the road of this process. The other thing I should note here again is just you'll see that the equity strategy is sort of cross-cutting across those dimensions, and so far as we expect there will be that will really be integrated within each of the program components. We also have envisioned at the sort of end of the year an opportunity to sort of assess the equity strategy sort of in full. So that's what you'll see indicated here is the equity strategy review. You all are this orange box, the Primary Care Program Advisory Committee. We wanted to just also acknowledge that there are a few other avenues for stakeholder engagement that will be pursued as part of this. First, there is an FQHC subcommittee of this advisory committee that has been established, and that will meet for the first time in 2 weeks. We expect that group to be meeting on a monthly basis as well, and advising on FQHC specific program design topics. So recognizing that FQHCs have, distinct characteristics and federal regulations, we're looking for some distinct FQHC engagement, and that group includes representatives from each of the FQHCs. We also, I think, know some of you from the MAPOC Care Management Committee meetings and expect that ongoing updates to that committee will continue and will be a part of this process. So on that every other month basis that the Care Management Committee currently meets. And then there are 2 other forums you'll see noted here. The first is a sort of broader non-FQHC primary care provider subcommittee. The second is the member advisory work group that CHN runs. And we're expecting that we will engage with those, both of those forums sort of as we go on a more as needed basis. I'll note that, in terms of the member feedback, we got a substantial amount of member feedback as part of the focus groups that were conducted under the program assessment. And so that member engagement and feedback very much will, informs the opportunities for improvement and the recommendations in terms of where this work will go. We are thinking that we need to move through some of the sort of program design and development phase before we can likely again engage meaningfully with members around that program design. So that's expected to start on some delay. And I would say the non-FQHC primary care provider subcommittee similarly is envisioned to come in down the line. So that brings us to your charge as a committee and turning it over to you all to talk a bit about who you are and your perspectives. Let me pause before we go there and just see, if there are questions or comments about any of the sort of background and context materials that we just went through. I think we could take a few moments here for any sort of discussion that may have brought up to you, and then we'll happily turn it over to you all for a round of introductions.
Hi. Go ahead.
I'm sorry, I'm Alice. Hi, I have a question around the race and ethnicity data. I know from the behavioral health, we've been looking at it, and it's really, there's a significant amount of folks who are not identifying in their race and ethnicity. And that column looks pretty big there. And I don't know if you have already taken that on as a challenge to be able to get that, more adequate results on that. That's a concern I have in general for Medicaid data.
Great question, and happy to ask. And just since we're streaming this, recording it, great. Anytime if you do first speak, just say introduce yourself, first name, last name would be great, and then we'll obviously do introductions momentarily. But thanks, Alice. Great question. And I know this is a struggle that has been an ongoing one at DSS for a while, and there is a separate group led especially by Susan Smith, who some of you may be familiar with, to help improve our REL data collection, race, ethnicity, and language collection. So that is in the works and is a separate work stream, something we are very interested in trying to, one, collect better data and also make sure our members understand why we're collecting it and why we think it's important. So that is ongoing work. And we know that there's a large number of unattributed or unknown race, ethnicity identifiers in our data sets. Go for it, Mark.
Thanks. Just making sure I'm lowering my hand and off mute. It's a great overview, Olivia. Thank you. I imagine we'll share more of our unique perspectives in our introductions, but if you don't mind, going back to the end goals that you describe on one of the previous slides, improving the biopsychosocial health and well-being of our members, especially for our most historically disadvantaged. So the question I have about that is, I've only seen is whether that means, I read that to mean improving biopsychosocial health means not just taking better care of asthma and diabetes patients, but actually having a reduced incidence and prevalence of psychiatric and substance use disorders and reduced rates of chronic illness, which are occurring at epidemic levels at this point. And so, one, I'm just looking for an affirmation that that is, in fact, that a healthier population, not simply better care for sick people, is one of our aspirations. And if so, I think it might be useful to extend beyond the reference to the OHS quality measure set to look at the Medicaid performance measures in the areas of pop health and preventive health and clinical care that were recommended by the Medicaid Transparency Advisory Board. And for those of you who may not recall, Governor Lamont issued Executive Order 6 just before the pandemic, establishing an advisory board to identify some superordinate outcomes that are Medicaid performance objectives, if you will. And so I guess I want to test out DSS's willingness to bring in those recommendations and to look at the extent to which those can be related to that broader end goal. That is, that there could be more specific things identified, not like quality measures per se, like a quality scorecard per se, as it is in the same way you did with maternity bundle. You have the sort of program goals and then you have quality measures, and they're kind of distinct. So I'm really thinking about informing, sort of filling out that picture of what it is we're trying to do and what we mean by a healthier Medicaid population.
I think great. I mean, Mark, I'm sure, I suspect all of us are very interested in improving the health and well-being at a broad scale of Medicaid members, and acknowledging that, right now we have over 1 million members, and people are obviously will be, with the public health unwinding, coming on and off. And so how do we do that? I think some of this will be about also defining the scope of what we can do with this, and making sure that we're scoping this work and of what's realistic and what we can include. I know some of the challenges we face with operationalizing some of the Transparency Board measures is actually getting the data and making sure we have access to accurate information. Though I think all of these things should be part of the conversation as we move this forward. And I don't want to limit that personally. Let me pass it over to Guy to see if he wants to add anything else to that.
No. I'm sorry. I just was shaking my head. I'm aligned. I think that it's needless to say, the definition of what do we mean by health and how we're measuring it is key to this entire discussion. And I'm channeling, I think, Ellen a little bit. Ellen, I'm not speaking for you. I'm just thinking about a previous comment you've made on the importance of what are we measuring, how do we know if things are working, things like that. And Mark, I take your comment in the same vein.
Thank you.
And I'll just add that I think we want to make sure we can measure those things, that we're in setting realistic measurement expectations, so we don't say we want to measure something that may not be easy for us to measure, at least initially. We may aspirationally want to, but recognizing that there may be some limitations to what data we actually have available to us, and whether it reflects that program success or not. It will be a question we'll need to come to. Tiffany?
Good morning, Tiffany Donaldson with the Connecticut Health Foundation. Thank you for this overview, and I also appreciate the questions from my fellow committee members. You were starting to allude to this, Brad, and I'm just wondering a little bit more about what are the expectations and the scope for this particular committee. If I look at the timeline, it's very aggressive. And then as I look at the overlay of work between the Venn diagram as well as the chart that you just showed, there's a lot of work that might be going on outside of this committee as well as within this committee. And I would really appreciate to understand what are your hopes in the scope for this particular work, and how does it also tie into the other work that's occurring between that Venn diagram and also what's on this chart.
Thanks, Tiffany. I think from the Venn diagram, you probably mean with OHS and with Office of State Comptroller's work as well. And we are very fortunate to have Kelly and Josh, respectively, from OHS and OSC here with us to help make sure that we're thinking about that as well. And so we're we're very appreciative, and I'll just say appreciative of the expertise on this advisory council. We think we're very excited about everyone here, and really tried to make sure that we're hopefully providing space for you all to provide comments and questions to us. In terms of Tiffany, like what the expectation and what other work will be going on, obviously internally at DSS and with FCG, with the Faulkner team, we'll be working to make sure we're presenting you with things that you can provide feedback to us on. We're not going to expecting you to develop things and to, obviously we will be looking for your feedback and your input. That is extremely important. And so we're hoping to bring you things that you can say, yes, here's from my perspective, here's what I'm thinking about X, Y, and Z. And so this is an aggressive timeline. Yes, I think we definitely acknowledge that. And so we will be doing work behind the scenes to bring you information for each of these meetings that you can respond to, and advise us as to, where this might make sense, what things don't make sense. Understandably, we may need to revisit, sequencing of topics, or do we actually need to try to fit in an extra meeting at some point in time to address that? I think these are all things that we'll have to address. We've done a little bit of this work similarly with the maternity bundle. You have been involved in that work, where we set a similar time frame, and I think we've been able to relatively stick to it with some adjustments. And I anticipate, this is our initial draft. We were going to have to revisit this depending on how things go. Guy or Olivia, you want to add anything to that? Ellen?
Yeah, thank you. I have 1,000 thoughts. I'm already on page 5 of notes, so I won't bother you with all of those. But a couple of thoughts to just sort of start. I think that when I opened the slide deck the other day, it felt like the first slide was very strong, and I'm pleased to hear more language about how we're going to build on primary care and not talk about it like dying and that it's, fundamentally broken. When we wrote our primary care report, and then I put it out to review with some of the primary care providers that I'd spoken to, they objected to that because I think in the appendix, there's a lot of good information about strengths and things we're doing well compared to other states. And I think we need to acknowledge that, and also not mess. We have to be very careful not to mess with things that are working. And so I think we need to look at that. Not, disruption is great for Uber. I'm not sure it's so great in primary care. And so there's a danger there that we should always be aware of. I also had to Tiffany's point about expectations. This is a very diverse group, and I heard Olivia say something like we can all agree, or I hope we can all agree. I doubt you're going to get there, and I don't know that you want to get there. You want to hear the differences between us, and that's okay. That's why we're here. And so I think that we need to acknowledge that, there won't be votes, or we're free to give our honest opinions, and everybody will be treated respectfully. I think I agree completely on the performance measurement will be key to making this work. We need to invest in monitoring real quality measures. And I heard maybe more in the appendix, but that data sitting in somebody's computer doesn't do a whole lot of help. It needs to get back to those providers in a timely way so that they can act on it. Data is not useful if it's not actionable. So if it's just punitive at the end of the year, you come back and say, gotcha, you were low on this or high on that. That's not helpful. I think that's really important to how we do it. And as to alignment, this is like the big Kool-Aid, but everything has to be aligned. But that does raise concerns with a lot of advocates because Medicaid is different. It cares for a very different, fragile population. And we need to have, sometimes measurements need to be different, expectations need to be different. And also, we're not in a position where we want to be losing any providers, especially primary care providers. So we can't be punitive. We can't impose co-pays on people to direct them in certain ways. And I think since the levers are different, the costs are different, expectations are different, and the population has different needs that we've talked about, I think trying to fit everybody into one size fits all, quality measures or performance standards is a very bad idea. And that sort of raises red flags for me. And I'll stop there, but I've got lots more if you want.
Thanks, Ellen. I expected nothing less and are glad you're here. And we definitely understand we don't expect everyone to be completely on the same page at the end. That's probably impossible, as you said, and that's okay. And we definitely want this to be a group that is willing to share their thoughts and disagreements, as well in a respectful, thoughtful manner. And so that is definitely what we brought together purposely, tried to bring together a very diverse group that has multiple representations. And going back, I think even to, there's a tension between some of our objectives is that we want to have alignment, but we also need to tailor it to the population. And there's going to be a tension in that. And so that will be part of the work that we will seek to use this committee to sort through. I know there's some other things, but I'll stop there. I know Olivia, do you want anything else to that? Polly?
Thank you, Brad. Hi, everyone. Polly Vanderwood, Yale New Haven Health System. Again, appreciate the opportunity to be here and the focus of this group. I was curious in the background, it talks a lot about, kind of reviewing where the state's been at with the PCMH plus programs. I'm curious, as we look forward to the work ahead, will you or Faulkner be bringing forward either things that you've learned from other states and other innovations, and really things that have actually material moved the needle on some of these measures and outcomes that we're looking to achieve? Or I appreciate what Ellen was saying, being able to point out where we feel we have certain strengths in the state and programs and offerings that may be differentiators for us. That we may want to bring those into the conversation as well.
Great, and I definitely think we want to bring in what's context from other states where things are occurring. I think there's a lot of change underway. Sometimes there's a lack of data about efficacy of those changes, which will be important to highlight as well. But that will definitely, we want to be informed by what others have done and what others are doing as we speak. So definitely, and I'll also say thanks for reminding me, Holly, and thanks for Ellen saying that there are strengths, right? There's strengths of our system as it is. I think acknowledging that is also important. And we have a large number of primary care providers that are taking that do see Medicaid members at this time, which is great. And so there are things that, and if you're looking across other states compared to Connecticut generally does fairly well on a bunch of our quality measures. I will say I think there's an opportunity for us to do better, and I think we can acknowledge both of those things. That there are things that we have strengths, but there's also opportunity for us to make thoughtful changes. And I think, Ellen, as you said, we have to be thoughtful about what we're doing and be really mindful of consequences of change. At the same time, not letting us stop at saying, "Hey, we're doing okay," but not preventing change from occurring. I think also would be concerning. So there's going to be a lot of tension in all of these pieces: tension on measures, tension on multi-payer alignment versus Medicaid specific issues. So this will be a key thing that I think will keep coming up as part of these conversations. Guy or Olivia, want anything to that? Great, and I expect we'll hear more from others as part of the kind of welcome context, and I think we've hopefully built in enough time for that. Olivia, is that next?
Brad, just wanted to, I'm not sure if you saw Karen's hand is up.
Oh, I didn't see that, I'm sorry.
Hi, everybody, and I can keep it brief. I'm not sure how well you can hear me because I am at a lobby day with 100 people lobbying for community health worker reimbursement through Medicaid, about 150. So I apologize for the noise in the background, but I did just want to echo a couple of things and say, you know, I think we have to have a both and approach when we're talking about the successes of Medicaid, in that in many ways we have a program that is stronger than in other states. And at the same time, that just isn't good enough. What's positive in the aggregate has not reached all communities equally. And the status quo does exacerbate existing disparities. And I think for that reason, it will be really helpful to define what the scope is and how, and the degree to which you are willing to think outside of traditional clinical settings and think about truly upstream prevention and how to incentivize that and how to foster collaboration to make that happen. I just think that's really important. And I did want to add also, just to echo the comments about the quality metrics. From the Quality Council, we made a number of public comments about those, and they really are deeply inadequate in terms of measuring progress towards equity. The underlying criteria that were used to choose those measures are problematic. So I know that there are validated data sets that could be very useful. But for example, the obesity metric that was chosen as the primary equity measure is not one that we would support as a metric in this context. So I hope we can have more robust conversation about that isn't restricted to just one meeting, because I think it's a much more complicated conversation. Thank you.
Thanks, Karen. Appreciate that. Yeah, and I think there's a lot on that we are looking to include on the table. Obviously, there is a tension of what's realistically, what we can actually achieve in terms of upstream interventions through primary care payment reform versus other interventions. And I think these are components. Obviously, we know both from members, providers, advocates, there's a lot of health related social needs that are important to address. How do we address those? Where does this fit into this? And this will be part of those conversations, part of the conversation that we're having in this council. And also just to acknowledge also the tension between various quality measures that may not completely adequately serve the best interests of Medicaid members. Those things will be things that we do need to discuss, and maybe multiple times. So just acknowledging that. And I do see Ellen, but was there another hand up? Did I miss someone? I feel like I'm, Ellen, I think you might be next.
Yeah, I'm sorry, I forgot to say this when it's in my notes, but and I'm working with the Council on Developmental Disabilities, and we're doing some work around raising awareness around access to primary care specific problem, a huge problem for people with disabilities, developmental and intellectual disabilities. And is there any, is there a way to include them in this as well? When we talk about equity, I mean, people talk about disabilities as an issue for disparity as well. And it's not just that, it's, you know, age, it's lots of other things too. I wondered if you're open to a more broad way of looking at equity and disparities in this.
I think we definitely should be thinking broadly, acknowledging that historical, I think marginalized communities, especially race and ethnicity, has been a major factor in driving health inequities, but there's obviously there's a lot of intersectionalities for individuals, and we should be keeping those in mind as we're thinking about health equity and disparities, understanding that it's probably impossible for this work to address every single one. And so keeping that in mind, that there's going to be a tension as part of this, but I don't think that would be at all outside of what we're looking to do. Again, acknowledging that racial disparities have been a huge driver of disparities, or racial inequities have been a huge driver. We need to consider other, including ability or disabilities, ageism, sexism, other problems that can drive inequities as well. How we do that, I don't know, but I think it's definitely something we want to be open to.
Oh, another hand. Robin, go ahead.
Yes, good afternoon. My name is Robin Anderson from the Ministerial Health Fellowship. And, you know, just all of the things I think that have been raised, I think are, you know, really, things that I think we should be really concerned about. But I think the other thing that I just wondered also as I looked at some of the things that were actually outlined there, to really think about, even with the council, do we have everyone that's actually providing services already for Medicare persons, Medicaid persons, and are they part of the council as well? Because I think it's really important that we have persons that are really part of this council that has continuously provided services for persons, I call them, that really deserve to have services. And what I think about also is that regardless of even insurance or whatever, and one of the things has been the community health centers, that have been providing these services, for everyone. I see Nichelle is on, but I didn't see anyone from the community health services incorporated. Also, who have about 200 CHCs across the state. And so, just when we're thinking about that, really making sure that we're inclusive of those persons that are already providing those services on this council as we, look at some of these things and tackle some of these actual, concerns that we have. And I do think that, we cannot do this work. I know when we talk about, health disparities, also, I do really feel it is inclusive of age, it is inclusive of gender, it is inclusive, it should be also inclusive of, developmental disabilities, which all exist and has exist. And then I think we can't do this also without really knowing and really understanding that a part of this is really to also break down systemic and structural racism that has been barriers as well, and will be barriers for this work if we don't really address those things. Thank you.
Thanks, Robin. And I'll just say, as part of the subgroup, we do have a specific FQHC subgroup, as Olivia alluded to, that does include CHC Inc. And the other, we invited all the FQHCs to participate in that work, acknowledging that there's special parameters as we're thinking about this that we need to be mindful of and include specifically the FQHCs in that conversation. So Nichelle is here, which we're very grateful for, but we will have a separate group talking about FQHC. We do want this group to kind of be a primary driver of the other work, but we know there's going to be specific FQHC discussions that need to occur that we'll also want to probably bring back to this group moving this forward. Again, I think scope-wise, again, we're trying to think about, we can't do everything all at once, and thinking about the population at large, and thinking about this program really being members, Husky Health members, including basically everyone, excluding dual eligibles, but really trying to design something that works for a large group, and also something that could work with the FQHC groups as well as the initial step. Acknowledging we need to probably do some more after that, as Olivia mentioned, like pediatric population may be a specific thing that we want to address, but realistically, as we do this work this year, that would be very difficult, I think, and unrealistic. Or specifically, for example, dual eligibles. There's a lot of challenges with working with people that have both Medicare and Medicaid for data issues and a bunch of issues, but these would be specific things that we want to look to the future for, probably not as part of this work, just given scope and capacity.
Seeing no other hands raised, I wonder if we have, I take that back, one more hand raised. Angela, go ahead.
Angela, you're on mute if you're trying to talk. Oh, we still can't hear you. Still can't. Well, do you, maybe when we come back to you, do you want to make your comment when we do our introductions, if that's okay? Unless anyone else wants to go, and we hopefully can Angela can get your audio working, or get your microphone working.
Okay, so to that end, I will move us over to this slide, which lists all of your names, committee members. So we thought, just to make sure we hear from everyone today, that we would go around. Perhaps lacking a better way to do this, maybe just alphabetically by last name. So in the order that you all are listed on these slides, and would ask each of you just to give a brief introduction, who you are, who you represent, and what your priorities for this work may be. So Robin, I know we just heard from you. If you don't mind, I will hand it back to you for a formal introduction, given that you are first on the list.
Okay, thank you. Again, I'm Robin Anderson. I'm the Executive Director for the Ministerial Health Fellowship, which is an advocacy coalition that addresses, that is made up of pastors, of community leaders, church leaders, community residents. Our primary focus is really to address, of course, the health disparities and to advocate for policy changes as it relates to affordable health and other disparities for persons of color. So I guess I'm here. I was invited to come here. Part of our work that we do, we also have the direct services work that also feeds our advocacy. So we have our community health workers, and we also have doulas as well, and then also recovery coaches that are also, in the community as well. So our, policy agenda items have been, of course, insurance affordability as it relates to raising the income level for Cover Connecticut to 300% to really make sure that even those persons that are, minimum wage goes up to make sure that they're still insured. We're also advocating for the elimination of financial assistance, financial debt, also medical debt. And then we do some work around oral health, as well as the, of course, reimbursement for community health workers, as well as for doulas. So that's kind of the scope of work that we're actually doing and that we're actually, continuing to advocate for. So in this work, also just making sure that this model is something that, will address health disparities, and that it is looking at everything through health equity lens, and that we do think about the preventive being upstream as well. So that's why I'm here.
Thanks, Robin.
Yeah, I guess I was invited to come.
We appreciate it, and we definitely invited you. So thank you for being here. I just want to say, if possible, we'll try and keep intros and sorry, just for time, and make sure I get to everyone like about 2 minutes. And so sorry to keep it tight. I just want to make sure we are able to get to everybody today. So we'll move on to, I think, Ellen. And Ellen, I think we've heard from you some great questions already, but if you keep it to about 2 minutes, that would be wonderful.
Sure. Yes, I'm Ellen Andrews from the Connecticut Health Policy Project. I'm a consumer healthcare advocate. I spend a lot of my time, on Medicaid, but we don't just look at Medicaid. We also are looking at insurance reform and affordability. And we look at policy. We're not an organizing group. We look at money, and we look at quality of care, the value of care that people get.
Thank you, Ellen. Jim?
Thanks, Brad. As you know, I have trouble saying hello in less than 2 minutes, but I'll do my best. Jim Carden from Hartford Healthcare Clinical Integration. One, thanks for inviting me to participate here, and I really appreciate the comments that our members have already articulated. Just to add to that, I'll express some concerns and where I think we need clarity. One, we're asking a lot of primary care. We're suddenly adding solve disparities, solve inequities, add higher quality. make sure that you're providing timely access, all of which are absolutely the right things for them to be focused on. But we also have to understand we have a workforce that is oversubscribed. They're doing tremendous things, but we have a real need for additional primary care support. And therefore, to meet even those goals is going to require a real transformation in the way they deliver care. And I think we need to think broader. How does this fit into the overall plan and vision for Medicaid in general? Because I don't think, although absolutely need more commitment of resources to primary care, in and of itself, it's not going to get us to the goals of what we've just articulated in the opening pages of this deck. It is going to take a complete realignment and really work across the delivery systems, however we want to define that, the expectations of what we all aspire and absolutely, in my view, have failed to deliver on the kind of care that we should be delivering to all the residents of Connecticut, regardless of where they live and what they do. And so it would be really helpful, from my perspective, to at some point during this committee lay in the vision for Medicaid and how this fits into it, and not just parse out we're fixing primary care, despite trying to align those across things. To me, this is still a whole lot of silos going on, and we're fixing bits and parts without an end state in mind. So that'd be really helpful. Thanks.
Thanks, Jim. Appreciate that. Stephanie?
Good afternoon, everyone. Stephanie Clark. I am the coordinator of the Health Improvement Collaborative of Southeastern Connecticut, which is a multi-sector, multidisciplinary, multicultural partnership of providers, social service and medical, municipal leaders, and just a bunch of individuals, community members who are interested in what we can do to look at what the state of health is by way of a community health needs assessment, create a community health improvement plan, and then outside of that, working together to dismantle the way that racism shows up in a way that influences all these social determinants of health and thereby health outcomes. So I'm representing that group. I'm also a person who spent quite a bit of her time as a single parent on Husky. So I have that lens that I'm also bringing to this group. So I was really impressed by the loftiness, if you will, of some of the goals, but also hopeful. And I just want to address one thing. I heard, and I don't know who said this, I apologize for that, but I heard something about race and ethnicity being a driver of inequities. And I just want to push back respectfully on that and say it is not race and it's not ethnicity, it is racism that is the issue. Thank you.
Thank you so much, Stephanie. Tiffany?
Good afternoon, everyone. Tiffany Donaldson. I am the president and CEO of the Connecticut Health Foundation, and we are focused on health equity for people of color, looking at a systems change lens, so really trying to change the system through legislative policy as well as administrative policy. What I want or hope from this group is that I appreciate all the comments that have already been made, and I agree with many of them. In addition to that, considering there are so many voices on here, we may not come up with agreement, but just a better understanding and consensus around how we need to improve health for those who are on Medicaid, most of whom are people of color, recognizing that if we improve the system for the least of them, they will help the most of them. And so we can really come up with some strategies that will approach the whole care of an individual that could be applied to multiple populations, but most importantly, addressing the population that has in so many ways been forgotten and hasn't been cared for as much as they should be. So my hope is that we come up with practices, policies, and ways that we can improve the lives of people who are currently on Medicaid and expand that to all who are in this state. Thank you.
Thanks, Tiffany. Alice?
Hi, everybody. My name is Alice Forster. I'm the CEO of Clifford Beers Community Health Partners, which is a parent corporation that has 3 subsidiaries, 2 mental health agencies, one in Norwalk, Mid-Fairfield Community Care Center, Clifford Beers Community Care, which is serves the New Haven Greater Region, as well as Youth Continuum, which houses, shelters youth 16 to 26, and working with homeless youth. I've been, since ACA has been passed, really working with my colleagues across all of our institutions to address the holistic care of individuals, in particular addressing the physical, mental, and social determinants of health. We have had 2 CMS healthcare innovation projects, one in 2014 to 17, where we tested and delivered Wraparound New Haven, which was a care coordination wraparound model, and we have some very interesting data from that I'm happy to share with everyone to talk about. We served about 2,000 individuals in this project and had a great reduction in inpatient stay and 0 impact on ED utilization. So I find some of this work very interesting. And we are currently in year 3 of another innovation project from CMS called Integrated Care for Kids. We're one of 7 in the country. And we are using a targeted case management alternative payment methodology to address a population of families in certain zip codes in New Haven. The zip code choice was only because the money that was set aside for the project wouldn't allow us to serve all 18,000 kids in New Haven. And we're working closely with DSS and DCF and Carelon and CHN to technically tier need, and then do a in-person needs assessment with families to really address what some of their identified needs would be. And, you know, to be honest with you, the social determinants of health are really the biggest identifiers, plus healthcare and overutilization of ED or urgent care due to not really being connected to primary care. So anyway, I'm here because this is something I've dedicated the last 15 years of my life to do, and I hope to be a bridge to the behavioral health innovations that are happening. So.
Thanks, Alice. Paul?
Nice to be here with everyone. Paul Grady, I work for Alera Group, and my day job is to help employers manage their benefit plans. I'm involved with the Connecticut Business Group on Health, moving to Value Alliance. I'm on the Cost Growth Benchmark Steering Committee. And, you know, I'm here because I think we need to meaningfully increase access to advanced primary care. I've been involved in initiatives to improve healthcare in Connecticut for more than 20 years. And to me, it feels like we're not making progress on primary care fast enough. I support the idea, the governor's goal of increasing primary care spending from 5% of our overall spending to 10%. And I think, you know, we can't do that fast enough. While my focus is on the employer commercial market, I do think that there's value to there being some alignment to across the markets. And, you know, I respect what Ellen said. We certainly don't want anything to be taken away from Medicaid, but I think that the alignment should bring more both to the kind of Medicaid and to the other markets. And, you know, one of the things we should do is OHS produced a report on 2021 primary care spending. If everyone hasn't seen that, they should take a look at it. And kind of DSS did lead the way, or I'm sorry, Medicaid did lead the way, spending 8% of their spending on primary care compared to less than that for the commercial and Medicare market.
Thanks, Paul. Angela? Oh no, we still can't hear you. Angela, we'll try to come back to you. Josh?
Thank you. Are you able to hear me? Great. So thank you for including me. I am a physician. I'm a practicing physician in the Department of Family Medicine, and I've been on staff at Stanford Hospital for almost 24 years. It'll be 24 years in July. I'm part of Stanford Health Medical Group, which is about 225 physicians. Stanford Health Medical Group is part of Stanford Health, where we have about 1,000 providers on staff at the hospital. I would say a third of those in primary care. Speaking about Stanford Health Medical Group, I'm at one site of about 20 different primary care sites. We have 17 primary care sites in addition to 2 pediatric sites and 1 walk-in center. My leadership role is Chief Medical Officer for Operations for Stanford Health Medical Group, which again is part of Stanford Health. I work with the Department of Internal Medicine, the Department of Family Medicine at Stanford Health, and we have residency programs at each of those departments. My role as CMO of Operations oversees the medical directors for primary care, for surgery, and for specialty. And prior to taking on this role, I was the medical director for primary care. So that's a little bit of background about me. This is a lot of information to take in. I'm grateful to be a part of it. My role as I'm listening is definitely going to be the voice of the physician. I think we speak a lot about the community needs, which are significant. I want to be the voice during this process of the caregiver, of the physician, of the provider, because we are asking a lot of an already burdened primary care world. And I need to make sure that we're sensitive to that because of the rate of burnout and the rate of frustration with our primary care physicians, primary care providers that we're already feeling. So that will be my voice again. I appreciate being a part of this group.
Thanks, Josh. And I just want to flag, I want to make sure everyone has an opportunity to say background information, and we'll probably run over a few minutes. Apologies on that, but just want to make sure people do have time to do that. And I think just going down our list, I think was unable to make that. And I know we didn't really schedule this around all of you, so we apologize for that and appreciate those who were able to make it today. Still, we'll welcome Yvette to coming next, and I'll move it on to David.
Hi, everybody. David Kroll. I'm a pediatrician. I'm the medical director for the Connecticut Children's Care Network. We're the only pediatric-focused, clinically integrated network in the state of Connecticut. My priorities are primarily around kids and the providers who serve them. So my priorities are the following. We have to continue to shift away from fee-for-service payment to hybrid or capitated payment approaches. We need to address children's health in the design and children's healthcare in the design, recognizing the long-term value proposition. We need to address early childhood adversity and social determinants. We have to include pediatric appropriate metrics. We need to facilitate partnerships with entities like schools, child welfare, home visiting, et cetera. We need to promote integration of behavioral health and social services in primary care. We need to consider risk stratification that accounts not only for medical complexity, but also for parental and social complexity. We need to support the creation of validated predictive risk algorithms for kids, including high-risk lists for pediatric care coordination and ensuring adequate payment for such services. And we need to include pediatricians in the government structures of the system that delivers these services. So thanks for including a pediatrician in this group.
Thanks for being here. Nichelle?
Good afternoon, everyone. My name is Nichelle Mullins. I'm the president and CEO of Charter Oak Health Center, and I'm also the board chair for the Community Health Center Association of Connecticut. And there are 16 member health centers in CHC Act. The priorities for this work for me involve ensuring that the community is a part of this process, and the best needs and the best interests of the community and the residents that we serve are actually the priority of this work, which is the mission of all of the health centers. And we want to make sure that access is one that is expanded, that access to quality healthcare is expanded, while always keeping the needs and the interests of the residents and the community members at our foremost focus. Thank you.
Thank you so much, Michelle. Doug Olson is, I know, actively seeing patients today and wasn't able to be here, but will hopefully be here in the future. Let me pass it on to Joe.
Good afternoon, everyone. It's great to be here. I'm Joe Caranta. I'm a primary care physician, and I'm also president of Community Medical Group and the Privy Quality Network here in Connecticut. Really excited to be here and looking forward to working with the group. You know, our organization is focused and composed of independent clinicians and independent medical practices. There are just north of 1,100 independent clinicians across 250 practices in our network, and all those groups are independent. And that really is the focus of our organization, is trying to help those independent clinicians and to provide the best care they can to their patients and their communities. We are really focused on the care transformation of those clinicians and helping them navigate down the path towards new and more complex delivery systems, looking at performance, looking at outcomes, quality, patient experience, and access, and really trying to help those clinicians achieve those performance improvements while maintaining an independent practice setting. So really excited to work with the group. We've had a lot of experience with value-based care design over the years and looking to help contribute to the work that needs to be done here.
Thanks, Joe. Mark?
Thanks, Brad. I couldn't be more excited to be here with this terrifically thoughtful and experienced expert group of people. I am Mark Schaefer, from Connecticut Hospital Association, Vice President of System Innovation and Financing. And I think an ask I would like to make, Guy and Brad, of you is to reconsider the timetable to allow this group the opportunity to thoughtfully consider the questions that Dr. Carden, Tiffany Donaldson, Nichelle Mullins, and others have referred to. How does primary care fit into a comprehensive strategy? What is the role of the community? And what is the role of other elements of the care delivery system upon whose success a primary care team depends? In my view, I can appreciate everything about the material prep for this was laser focused on a model of primary care reform that is about building teams and then holding accountability for quality and outcomes. And I think there's an opportunity cost to having a narrow focus. Although we could get it done, we could spend 3 years trying to stand up a stool with one leg, and ultimately it's an impossible feat, and we won't be able to achieve the objectives we're trying to achieve around the well-being of the Medicaid population. I continue to hold in my mind that we have an obligation not to let happen what happened at the beginning of the COVID-19 pandemic with regard to extraordinary adverse outcomes for people who were experiencing the long-term effects of structural racism and being in economically marginalized communities and that sort of thing. And I believe that if our focus for the next few years is primary care, or we're not working on parallel sort of a comprehensive approach, I really don't think with the next pandemic, we're going to see a fundamental change in the outcome. And I think we have an obligation to take our time and set the foundation for effective planning, making best use of what I think is an extraordinary array of people you have around this table. So thank you for that.
Thanks, Mark. Karen?
Hi, everyone. I'm Karen Siegel. I'm the Director of Policy at Health Equity Solutions. We are a statewide nonprofit focused on anti-racist policies and practices with a race-forward definition of equity. We engage in organizing, education, outreach, and consulting work. And through that consulting work, we have worked with a number of state agencies across the United States on similar policies. And I just wanted to share that one of my priorities for including us in this work is to learn from the lessons of other states that when we don't think holistically, when we don't address needs that occur outside of the clinical setting, when we do take an overly narrow focus to incentivizing or to accountability, we don't actually move the needle on quality, cost, or equity. And so I just want to reiterate what Mark was saying, that I would really hope that this group would consider taking a comprehensive look at how primary care interacts with other aspects, other systems, and to just give that its due consideration. Thank you. And I'm also sitting right next to Angela Harris at the moment, if you would like to try again to see if she can be heard.
Yeah, that'd be great. Angela?
Go ahead.
Okay, so you can see me, but hear me through Karen?
Yep.
Okay, perfect. Angela Harris, I'm the chair of the Phillips Health Ministry as part of Phillips Metropolitan CME Church in the north end of Hartford, where many of the folks in our community are Medicaid patients. So I come with a unique perspective because this is the community we serve. I would hope that the use of the brain power gathered would allow DSS to think outside of the box as relates to the improvement of the quality of life, increasing preventative care, rebuilding trust in the healthcare systems that was evidenced during the pandemic, needs improvement. I would also like to see use of community health workers at livable wages to help increase full utilization of physical, mental, and behavioral and dental health care as provided through Medicaid. I'd like to see this group figure out how to minimize the life expectancy gap in the urban centers and suburban communities across the state. There should not be a difference of 15 to 20 years difference when folks are living 3 miles apart, as we have in Hartford to West Hartford. I'm very concerned about this group not taking a look at dual eligible patients, which is a critical population in communities of color. If we don't take care of our elders, we're not doing our job. And I understand that it might be an inconvenience for the statistics, those that are collecting data, but we really do need to address this population. And I also like, in thinking outside of the box, what can DSS do to increase access to affordable quality food in lieu of prescription medications after diagnosis? If we can actually also analyze the provider landscape to address access, that concept is not limited to health insurance alone. We have providers that are not continuing service to Medicaid patients, and that's an issue. I'm looking forward to working with all those gathered, and I definitely would like to make sure that we have a comprehensive, holistic approach, leaning on health equity in everything we do. Thank you.
Thanks, Angela. I know some folks need to leave right now. So if we didn't get to, so if Kelly, Polly, Josh, if you need to leave, we will make sure to pick this up at the beginning of the next meeting. If you'd like, if you are able to and want to, Kelly, go ahead. But if you need to drop, we totally understand.
Sure. Thanks, Brad. I'll just go quickly for the sake of time. So hi, everyone. My name is Kelly Cinco. I'm the Director of Healthcare Innovation at the Connecticut Office of Health Strategy. For people who don't know, we're a state agency, a sister state agency to the Department of Social Services. And our mission is to implement comprehensive data-driven strategies that promote equal access to high quality healthcare, control costs, and our hope is to ensure better health for the people of Connecticut. My priority, or the OHS priority for this work, is to make sure we are aligning with DSS in everywhere we can. especially with some of the primary care initiatives we're doing, as Paul Grady referred to, the primary care spending target, and figuring out how we can increase investment in primary care, which we think is extremely important to coordinate care across the system. So thank you all very much.
Thank you, Kelly. Polly, if you need to jump, understand, but if you'd like to say.
I can go quickly. Thank you, Brad. And again, very pleased to be here. Polly Vanderwood, I'm the Executive Director for Population Health and Clinical Integration at Yale New Haven Health System. Our team really sits and works across all aspects of Yale New Haven. So we work very closely with Northeast Medical Group, our large 130 location multi-specialty and primary care practice. We work with each of our hospitals and delivery networks, and we are at the kind of forefront of innovating payment innovation, care transformation, social drivers of health screening and intervention programs, and really helping to transition into more value-based innovative payment models. And we also work hand in glove with our Office of Health Equity and Community Health. So appreciate, one of our aims is to improve the health outcomes for the populations that we serve and also the communities in which we operate. So appreciate the lens of really looking as holistically as possible to really across the care continuum and into innovative models in the community. Thank you.
Thanks, Polly. And I know Josh had to run, so we can wrap and we can kick off the next meeting with, we can ask Josh to verbalize his introduction he put in the chat, as well as hopefully Yvette and Doug when they're able to join us. So just to wrap up, we just appreciate your this group is a group of folks who have a wide variety of expertise, and we really will be looking to you to provide continued commentary and thoughts and advice similar to what you did in your very brief introductions. We will continue to be looking for that throughout this. And so just a big thank you for coming today and to participating. And indeed, anything else you want to say as we wrap?
Yeah, no, appreciate it. Looking forward to this. And I know conversations like this are best when we're open and honest. So looking forward to people's thoughts.
Agreed. And we'll be sending out further calendar invites and be seeing you all soon. So thank you so much.
Go on.